Hello. Welcome to the second session of a journey through the Psychedelic Revival, sponsored by Penn Nursing. My name is Pac, and I'm a psychiatric mental health nurse practitioner student here at Penn Nursing. At the start of my nursing career, I worked in the emergency department for 3 years, where I specialized in patching up bullet holes and infusing copious amounts of blood products in order to reanimate lifeless bodies. The trauma room was where I flourished, and I loved working with the trauma team. But little did I know I would become a trauma patient myself, but not exactly the physical trauma I was used to. Mental trauma is something that cuts much deeper. After witnessing so much death and despair throughout the COVID-19 pandemic, it's hard even now to process the reality that was these last 3 years. Without a doubt, the unseen trauma is the hardest one to treat. I now look forward to my training as a mental health trauma nurse at Penn Nursing, one that helps treat the pain and the suffering within. The psychiatric mental health field isn't an easy one, and we'll need every tool in our arsenal to help us in the aftermath of this pandemic. As of recently, psychedelics have found their way into the toolkits of many clinicians looking to help individuals overcome trauma. There's still a lot to learn about psychedelics, but I'm excited to be part of this learning series, where we hear from both people who have benefited from this therapy and from the leaders in the field who have extensive experience with psychedelic medicines. We'd like to thank Dean Villarule for supporting this event. The Dean's support for innovation here at Penn fosters learning experiences such as these. We hope this series will spark critical discussions across disciplines. In attendance tonight are nurses, physicians, researchers, therapists, and many others from a variety of professions who are eager to learn more about innovative approaches to modern-day health challenges. To begin this conversation on psychedelic medicines, we're first going to start each session with a short video to humanize this type of healing. Tonight, Carolyn Nelson will be sharing her story about how psychedelic-assisted therapy helped her heal from the trauma she experienced. Afterwards, our speaker for tonight, Andrew Penn, will be talking about psychedelic medicines. They'll be talking about it for about 45 minutes, while he'll have plenty of time for Q&A at the end. This is a unique opportunity to have a leader in the field answer your questions. We invite you to engage with us. Please use the Q&A function rather than the chat for any questions that you would like to ask Andrew. You'll be able to like your favorite questions, which will help us identify which questions should be prioritized. We'll do our best to make sure that our speaker answers as many questions as possible tonight. If you have any questions that aren't specifically directed at Andrew tonight, please post them in the chat and we'll do our best to answer those questions separately. And now for our video.
My name is Carolyn Nelson. I am from Charleston, South Carolina, and I am an emergency room nurse. So I am the baby of 4, and I'm the only girl, 3 older brothers. The oldest brother was 6 years older than me, and he was kind of my end-all be-all. He just was the most amazing individual. He and I just had a connection like no other, and my brother committed suicide, and he didn't die from the incident. Eventually, though, had to make the decision to take him off life support. And that was probably the hardest decision I've ever made in my entire life, thinking if I had to say goodbye, I was really saying goodbye. I was really struggling with not being able to sleep well, not feeling super happy, not wanting to be around certain people. Also, headaches were just horrible because every time I closed my eyes, I could just see the same scene, over and over and over. I knew it was necessary to meet with someone, and so that was kind of the turning point. The MDMA study is patient-centered with professionals that know what they're doing. This was obviously something I had never experienced before, where I was going to have therapy and really digging in to trauma and learning more and figuring out how to move forward. And that was a big thing, to be able to share in these experiences with basically two strangers. I was just glad to feel comfortable with them and to take this, and I mean, it sounds wrong to call it a drug, because sometimes drug, you know, I would say therapy, to take this therapy. And they are some of the most amazing people, and I would not be where I am without them in this therapy. My experience with psychedelics, it softened me a lot. And not that I'm a harsh person or a hard person, I'm very loving, but it just softened the edges. It's been 13 to 14 years, and so I feel like it was just yesterday. I feel like, I always joke, I say, oh my gosh, can I pretend like I haven't done it? Can I please get back in? Because I know what it did for me, and I want it to be for others as well. I think that there are so many people out there that deserve to have this type of therapy to help them kind of get out of the box or their internal jail, or however you want to call it. Gosh, it can make the world a better place.
Thank you, Caroline, for sharing your experience with us. Your story is incredibly touching, and it inspires hope to those still actively seeking innovative treatment options for their trauma. This learning series is designed to explain psychedelic-assisted therapies over a course of 6 sessions. During the first session, we learned about the history of psychedelics and the most common substances used. Tonight, we'll discuss what's involved in the preparation for therapy using psychedelics and what happens during and after each session. After tonight, our next sessions will take you through the pharmacology and neuroscience behind psychedelics. Please note this will be held on Tuesday, February 15th at 6:30 p.m. This will be followed by information about current research being conducted, as well as clinical applications, which will be held on March 2nd at 6:30 p.m. These presentations will be followed by our last 2 sessions, which will be panels with experts in the field discussing the future of psychedelics and how people will gain access to them going forward. Please note that you will need to register for each session separately. Without further ado, it is my pleasure to introduce tonight's speaker. Andrew Penn is a University of California, San Francisco trained psychiatric mental health nurse practitioner. He serves as an associate clinical professor in the UCSF School of Nursing and practices in San Francisco, VA, where he works with nurse practitioner residents and students. He has completed the CIIS, MAPS, and USONA trainings in psychedelic-assisted therapy and has worked as a study therapist on a Phase 3 MDMA-assisted therapy protocol for PTSD. Additionally, he is a co-investigator to the USONA-sponsored study of psilocybin-assisted therapy for major depression. He's the co-chair of the SANA Symposium and a co-founder of the Organization of Psychedelic and Entheogenic Nurses, an organization focused on advocating for the perspective of nurses in psychedelic therapy. Andrew has published on psychedelics in both the American Journal of Nursing and the Journal of Humanistic Psychotherapy. Before we move on to the presentation, this is a reminder to please keep in mind that the information shared here is for educational purposes only. Penn Nursing and the speakers in this learning series do not endorse or encourage the use of illegal substances. With that, I offer a warm welcome to Andrew Penn. We appreciate your time with us tonight to talk about such an interesting topic.
Thank you, Pac, for that introduction. Let me just get my slides up here. Great, I hope everyone can see that. Yeah, thank you again for that introduction. So yes, my name is Andrew Penn, and I want to acknowledge before we get started here tonight that I live and work on unceded Ohlone Ramaytush land here in San Francisco. which is important to note, especially when we talk about this work, much of which has origins in ancestral indigenous practice. So I think it's important to make that acknowledgement at the beginning. I also want to thank the Penn School of Nursing for the innovation and invitation, especially to Sandy Sandberg and Kwasi Adesi for their tireless leadership in putting this series together, and also for Reconsider's sponsorship of this series. I do want to acknowledge that I did receive salary support from MAPS and USONA for the work that I've done on their respective clinical trials, but I have no other commercial conflicts of interest, nor do the sponsors of this series. And if it wasn't obvious already, MDMA and psilocybin remain Schedule I drugs and are not FDA approved, and there's nothing in this presentation intended to encourage illegal drug use. What I would like to do tonight is to present a qualitative and theoretically driven presentation that I am hoping will inspire those listening to think about how to describe and study the care that we deliver as psychedelic therapists. And this presentation is centered in my training as a nurse, but the skills that I'm going to describe in guiding a psychedelic session are not exclusive to nursing, although they do align with the native sensibilities and ethos of our profession. You know, one of the things that I really love about psychedelic therapies is the way that they decrease the differences between the varied professionals within healthcare and encourage cross-disciplinary collaboration. So if you are a psychotherapist or a physician, this presentation will have relevancy to your work. And I hope that you'll be reaching out to your nursing colleagues to improve your studies and your clinical practice. And as such, I will use the terms nurse and therapist interchangeably tonight. If you are requesting continuing education units for this event, do keep an eye on your email box, the one that you registered with, as they'll be sent out to you. So without any further ado, let's talk about what happens in a psychedelic session. That's our objective tonight. So here is the fundamental problem that Matthew Johnson, our colleague at Hopkins, captured very nicely in this tweet. He said, psychedelic therapy is more psychotherapy than most pharma companies, and I would add, and psychopharmacologists and neuroscientists know how to deal with, and more pharmacology than most psychotherapists know how to deal with. And I think he's really onto something here, because what is really not being captured in a lot of the conversation is about the care that we deliver in these therapies. In fact, most psychopharmacologic studies are really kind of a black box. You know, we have a person who's suffering from a condition, let's say depression, we give them a medication, and 6 weeks later, out comes this outcome. Do we really know what happens inside the black box between the beginning of the study and the end of the study? Often we really don't. And I would posit that with psychedelic therapies, that what happens in the black box is critical to the outcome, that this is not your standard psychopharmacologic study where it really doesn't matter what happens between those 2 points, but that really what happens in that in-between space is critical. Because if we take that out of the condition, we have one way that we look at healthcare right now, which is that, you know, in medicine, often we think of a disease first. We think of, you know, even if you spend some time in an ER, you'll hear somebody talk about the MI in curtain 3. And in this case, the disease really takes center stage, and the person can often get kind of eclipsed by the pathology. Now, this objectivity has led to some incredible treatments, you know, things that we might call curative-based care. But the problem is, especially when we apply these to some of the more nebulous pathologies that we work with in psychiatry or, say, in palliative care, is that we have gotten this idea that perhaps we can take something like pain in psychiatry, and that might be the emotional pain of having a difficult childhood, and that there's suffering. And so often we kind of conflate the two things together. You know, attorneys will talk about this in one sentence of pain and suffering, right? But there's this old idea, I believe it's based in Buddhism, that pain and suffering are not the same thing. That the pain may not be negotiable, but suffering we have some agency over. And that suffering often takes the form of either avoiding the painful experience or being overly attached to it. But this idea that we can just sort of knock this out as an ailment has led us to these kind of lytic treatments in psychiatry. We talk about anxiolytic drugs for treatment of anxiety. And this is an idea that's borrowed from microbiology, that we can just kind of poke a hole in that cell and it will die and the problem will go away. But those of us who work in this field know that it's often not that simple. And I would suggest that at least up until now, most of psychiatric interventions, this may not be the case for psychotherapy, but that a lot of psychiatric interventions are palliative, and that's okay. That's no knock on the palliative as an orientation, but really we're mostly reducing symptoms and hopefully by doing so improving quality of life. Now let's bring nursing into this conversation. So we have Florence Nightingale here, somewhere in Crimea. Now nursing looks at illness in a different way. So we look at a disease, sure, but we think about that disease as embedded in a person. The person is what comes first. The disease comes second. And that person with their disease exists on a wide field of their possibilities, their existence, if you will. And also existing on this field are things such as their family and the people that care about them, their important ideas and work and relationships. These are all parts of what make us who we are. Now, sure, we as healthcare professionals may be part of this landscape, but you see, we're really not the main attraction here. We're just one small part of helping this person in their wide field of existence. And this is what Gene Watson, who I'll speak about in a moment, has called curative processes or a curative process. In the psychedelic therapy model, it's really important to understand that there are three parts to it. And a lot of times when the popular press gets a hold of this story, they really focus on the medication. They focus on the drug session. But I really want to emphasize that the drug session is bookended on both sides by periods of psychotherapy. Now, it depends on the therapy model that we're using, the protocol, but it may be anywhere between 6 to 8 hours, may even be more than that. And for some people, it probably should be. And in that therapy session, the preparation therapy, so no drug is involved, this is where we begin to establish trust and safety. And it's important to understand that this is not a one-size-fits-all. Right now, in the controlled trials, we're sort of forcing it to be a one-size-fits-all because we have to in order to have a consistent model for comparing outcomes. But when we get this to hopefully a point in the future where this can be done clinically, it's very clear that some people are going to need more time to develop this sense of trust and safety. And this may be informed by trauma, this may be informed by cultural considerations, this may be historical. There are some people who feel less comfortable in medical settings than others. And so we need to keep that in mind. And during that time, we're providing psychoeducation, we're getting to know the patient, we're hopefully setting some intentions for the psychedelic session, while at the same time holding our expectations loosely. And the reason for that is because there's an old adage in psychedelics that you don't always get what you want, but you'll get what you need. And so sometimes if people hold on to what they're hoping for too tightly, they can be disappointed and they can actually lose sight of the other things that might be available to them during the session. We're also creating what we are calling set and setting and support. So the set refers to the mindset, the things that the person is thinking about when they come into the session. The setting is all of the physical aspects and also the relational aspects between the patient or subject and the therapist and the external support system. So that's essential that we set that up before they come into the drug dosing day, which generally is an all day long session. Depends on the drug, but it can go anywhere between 6 to 10 hours, maybe shorter if it's something like ketamine. Now, during that time, after the drug is ingested, there may not be a lot of interaction that takes place. The person may be having a largely internal experience, and that's fine, because we're going to have plenty of time to talk about it after the therapy is over. We don't forcefully direct people into talking about particular things. We don't have specific exercises. We're not doing CBT, for example, in that session. We're not doing thought records or something like that. Mostly what we're encouraging people to do is to direct their attention inward. There's a sort of a mantra of trust, let go, and be open. And there's music playing in the background. And music helps to set sort of an emotional tone for the day. And it also creates kind of a current in which the person can follow, because music is usually kind of flowing from a beginning point to an end point. And sometimes psychedelic sessions can feel sort of frozen in time. There can be something called time dilation. So this music helps to create this current for the person to follow. And then starting the next day after the drug session is over, so we've usually sent the person home with a support person, they're going to come back, or we're going to meet on Zoom, and we're going to begin integration. And integration is the therapy that happens afterwards. And during that time, we're going to talk about what happened the day before. Sometimes people had strange experiences or bewildering experiences. It can be a little bit like talking about a dream. As you're saying it, it's like, well, this sounds sort of silly, but I think it was important. And so we try and make sense out of the experience. We explore it, we interpret it. We also look for opportunities for change in the day-to-day. So a lot of times there's this period of a few days, maybe even a few weeks afterwards, sometimes referred to as an afterglow, where people are really thinking about their lives, and they're really thinking about how they might like to make changes to their lives to help themselves feel better. And we want to encourage people to make those changes in a thoughtful way. And we talk about bringing this back into what Betty Eisner referred to as the matrix of their life. So this is the larger setting in which they live. So this is not only their family, but this is also their work. It's also the way we think about these kind of non-ordinary states of consciousness within our culture. That's all part of the matrix. So we're bringing this back to their day-to-day life. And as I started thinking more and more about this, I thought, nursing is so naturally aligned with this model. So this is, to the right, this is Bruce Poulter, who's a nurse in Boulder, Colorado, and his partner, Marcela Otalora. And they are MAPS therapists. So this is sort of a mock-up of one of their sessions. And I thought, this is a lot like midwifery. The nurse midwifery, it's not necessarily about curing an ailment, because pregnancy is certainly not an illness, but it's something that needs guidance. It needs care. It needs support. You might need somebody to help you out if you get a little stuck. You might need somebody to tell you what to expect. Reassurance is powerful medicine in those moments. And I think about this as sort of the ICU. It's like the intensive caring unit. We talk about health care, but that word care often gets kind of lost in the shuffle. So I want to re-centralize care. And I am not an original thinker on this. So this is a fantastic find that I found some years ago in the MAPS archive. So this is Kay Parley. She was a nurse in Saskatchewan, Canada. She was working with Humphrey Osmond. So if you know a little bit about psychedelic history, you may remember that Humphrey Osmond was the psychiatrist in Canada who was working with LSD and patients with what we would now call having alcohol use disorder. And I found this remarkable article in the 1964 issue of the American Journal of Nursing called Supporting the Patient on LSD Day, which was really just astonishing to me. And in it were these gems like the nurse-patient relationship during LSD treatment is, I suspect, like that between partners on a mountain climbing team, warm, cooperative, intimate, and yet objective. I mean, that was so ahead of its time. Kay, to the best of my knowledge, is still alive. She's, I think, about 99 years old and living still there in Regina, Canada. And she's written an amazing memoir, which I wish I had time to get into, but you should definitely take a look at that, called Inside the Mental. She has an amazing story of her own. And of course, Kay is one of many women who have carried medicine over the millennia. We know in many traditions, women were the medicine carriers, and this is just really a contemporary example of that. So we wanted to continue this story. So we were so astonished that we found this in the American Journal of Nursing that working with my colleagues Carolyn Nelson, Stephanie Hope, who spoke at the last Penn Nursing session, and Billy Rosa, we wrote the follow-up article to this 57 years later in last year's cover story of the American Journal of Nursing. And when we told the editors that they had run this article in 1964, I almost think they didn't believe us until they checked their own archive, because it seems so far away from nursing practice now. And we really wanted to start to change the conversation around that. And I think this series that UPenn has been very pioneering to put on is a great example of how that conversation is changing. So I started thinking about what kind of qualities does a psychedelic guide need? And of course, Timothy Leary had opinions on many things, and no surprise, he had opinions on this too. In this sort of whimsical description of a psychedelic guide would need to have these skills of being a patient as a first grade teacher, as wise as a guru, the sensitivity of a poet, as creative as a science fiction writer. Fantastic gesture, a little hard to quantify, a little hard to set into a formal praxis. So Janice Phelps, fortunately, who's a colleague of mine, she's the director of the California Institute for Integral Studies Certificate in Psychedelic Therapies and Research, which is really the original program to train people to be psychedelic therapists, wrote an article back in 2017 talking about these qualities of a psychedelic therapist, being that of empathic abiding presence, trust enhancement, spiritual intelligence, understanding how psychedelics affect both the physical and the psyche, being self-aware and having ethical integrity, and being proficient in complementary techniques. And so as I read this, I also started thinking a lot about nursing. Now, wait a second, this sounds like a lot of what we do just naturally in nursing. And then I remembered back to my nursing theory class, and somebody who is very well known in the nursing field is Jean Watson. And Jean has spent the 50 plus years of her career really describing what it means to care for another human being, and to really describe this ineffable quality that we have in nursing. And when I approached her about co-writing this article, she was only somewhat peripherally aware of what was happening with psychedelics. This is her book from, I believe, 1996, which those of you who are familiar with Alex Gray's psychedelic painting work, you'll see is on the cover of her book. So, she really was quite prescient about these ideas well before this field of psychedelic therapy had emerged in its more contemporary form. So I approached her and I said, would you be willing to co-write this paper? And very graciously, she said yes. So we wanted to fuse these two ideas, that of Janice Phelps and that of Jean Watson, into something that I'm calling psychedelic Caritas nursing. Caritas is the Greek word for care that Jean Watson uses as part of her theoretical work. And really at the heart of this Caritas process is the relationship. So that the central idea here is that we alleviate suffering through the caring relationship between two or more human beings. And my hope is that if we can do that, then what we are actually doing is we are widening that nucleus of suffering that orbits around pain. So what do I mean by that? So, I once years ago had a patient with PTSD ask me in my practice, they said, if I take medicine, will I forget about the trauma that I had as a child? And I said, absolutely not. I wouldn't want you to do that. Or actually, they asked me if they went through therapy, if they would forget what they had experienced. And I said, absolutely not. I wouldn't want to take that away from you, even if I could. But what I would like to do is to change the relationship that you have with it, so that there is more space between that painful experience that you had as a child and the suffering you experience. And in that widened orbital, there is room for all the other parts of your life. Because really, so often, the suffering really resides in the story that we have about our experience. So we formalized this into an article that was graciously published in the Journal of Humanistic Psychology. I'm happy to send you a copy of this, or it's on my website if you want to download it. So this presentation tonight is really an adaptation of that article. And my hope is that as we begin to establish these therapeutic models for psychedelic therapy. And there are many proposed models, many of which are complementary with each other, to things such as adapting internal family systems or holotropic breath work or acceptance and commitment therapy, that this idea of psychedelic Caritas can be complementary to all of them, because it's really not a theoretical framework in the same way that a psychological theory is. This is really a map for a way of being with patients that I think that nurses are very well suited to doing quite naturally, and that we can certainly teach our non-nursing colleagues. So what does this look like? Here's an overview. So really, you can sort of divide it up into two rough categories. So there's tending to the patient and tending to the self and the world. And so this tending to the patient is based on a trusting relationship in which we learn and teach. We learn from and we get to teach our patients. They teach us, we teach them. That we are authentically present for the patient and supporting the inner world, and supporting that with loving kindness and equanimity with both positive and negative things that may emerge during the psychedelic session. Additionally, we get to have some fun here. We get to play a little bit. We get to be creative in the way that we do this. And then tending to the self and the world, that we as therapists, as nurses, are cultivating our own spiritual practice so that we are more able to be attendant to suffering, help people make meaning out of difficult things in their lives. This may be making whatever we need to do in order to feel comfortable with the parts of life that are maybe a little more non-ordinary, maybe the more spiritual, mysterious aspects of life, particularly those that might attend to illness and death. That we create a healing environment in all ways, so that's the physical environment setting, and we take care of the physical body, because while this may be an emotional process for the patient, this may be a psychological process for the patient, we mustn't forget that it takes place in a physical body, and that we want to help people not only support the physical body, but really incorporate that into their therapeutic process. We'll talk more about each of these in turn. The image that I like to think about as we're beginning this process is that the patient and the patient and the therapist, we are co-creating this sort of house of healing, if you will, together. And this is a remodeling project of the patient's internal world. And so the therapist in this role has the job of being both a collaborator and somebody who knows how to help build things. And the container we're building is comprised of both physical, so it's the physical setting, it's a safe and hopefully pleasant place to be in for the duration of the therapy, but it's also psychological and interpersonal. So by that I mean that the therapists know the subject well enough, they know the patient well enough, that they know what kind of themes might emerge, and that the patient feels trusting of those therapists. So those three parts comprise this container that the psychedelic therapy takes place, this vessel, if you will. Now, if you've ever gone through a remodeling process, you know that this can be kind of messy. So this was my place here in San Francisco, very 1985 vintage kitchen complete with peeling laminate and all sorts of unpleasant things that we decided a few years ago we were going to tear out and remodel. And that was going to be a messy process, because in order to get to here, we had to go through this. And it was a messy process because we were living here too. So it was kind of like a big game of construction Tetris. And in order to get from this kitchen on the left to this kitchen on the right, from which is where I'm sitting today, we needed a guide. This wasn't something we were going to be able to do ourselves. And this was Pascal, our wonderful contractor. And so he really was our transformative guide. We couldn't have done it without him. Now, a lot of people have this imagination, if you will, call it a fantasy, that psychedelic therapy is going to be this quick fix. You know, the media really encourages this narrative that people have been suffering for a long time. They join one of these studies and boom, they're cured. In our study, we call this the Pollen Effect, from Michael Pollan's writing. And as much as I appreciate what Michael Pollan has done in really translating a lot of this work to the general public, it really has kind of created this idea that this is going to be a curative process for people. And while it may be for some people, there's a lot that happens between A and B, and the reality of this can be somewhat nonlinear and somewhat recursive, and sometimes really, quite frankly, a struggle. There's also been a lot of sort of innovation, might be one way of putting it, imagination, that maybe this could be streamlined down to doing this with an app. Heck, we order our groceries with a phone, we hail rides with a phone. Why not do psychedelic therapy with a phone? I worry about this, quite honestly, because what I hope to convey here tonight is that at the core of this treatment work is based in a human caring relationship. And I think that's a difficult thing to convey through a screen. So let's walk through this. So before we can begin any kind of therapeutic process, we have to be invited in. So we can't just impose ourselves onto a patient. They have to be willing to let us in, just like I had to be willing to let Pascal in to tear down my walls. And this is going to require different levels of sensibility from with different patients. One of the problems that we've run into in psychedelic research is that our subject pools tend to be very white. They tend to be upper middle class white people who are our subjects, which is a problem because it doesn't represent the populations that are going to need. It's not inclusive of all the populations that are going to need this treatment. And the reasons for that are many, and they really go beyond this conversation tonight. But we really need to be thinking about, are we developing a meaningful relationship with the communities that we are treating? Or are we just hoping that they come into our studies so that we can get data and publish papers? Because that's really an extractive and exploitative model. So we really need to think about, how do we create meaningful and enduring relationships with the communities who are helping us to create this, to do this research, and who are essential for us to be able to successfully do this research. Once the relationship begins, we then begin to learn from the patient, and hopefully the patient begins to learn from us. And this is a process of building trust. And I also want to point out that this is, all therapy is time limited. Now, some therapy might be one session, some therapies might be 10 years, but they're always inherently time limited. And so the same is true for psychedelic therapy. When our work is done, we end the relationship and go forward. So this trust begins at the beginning. And so once we have this trust, then that allows for something that is sometimes referred to as the inner healing intelligence to emerge. And inner healing ability, inner healing intelligence is probably one of the more nebulous terms that is thrown about in psychedelic therapy. And different people define it differently. One of the ways that I define it is nature. It really is, and this resonates with something that Florence Nightingale said about healing. This is over 150 years ago. She said that really it's nature that heals the wound. And what we do as nurses is we put the patient in the best condition for nature to act upon that patient. And this was echoed by Annie Mithoefer, who many of you know as one of the PIs in the MAPS MDMA studies. And she said something very similar, that really it's this trust that is developed between the patient and the therapist. Bidirectional trust, so it's not just one way, it has to go both ways, is what allows for the participant's inner healer to emerge. I was fortunate to be able to look through some transcripts from qualitative studies that were done by Alex Belser and Cody Swift at the NYU study of psilocybin for cancer anxiety, and looked for examples of what this looked like. And this was from a subject in that study. Names have been changed, but talked about feeling so protected and couldn't have felt more protected. That real sense of trust and safety, and that was created by these kind of recursive loops of the therapist getting to know the patient and then stating that back, stating in a clarifying way, and that really communicates that we've understood each other, and that is foundational for this to work. Once that trust is established, we have to behave in an impeccable way, because our patients are going to be in a very vulnerable state in these psychedelic spaces. And it's that impeccable behavior and that presence that continues to deepen and maintain that trust. Once we have that trust, we can begin to see the world as they see it. And the patient, to some extent, sees the world as we see it. And it's that exchange that happens in the preparatory therapy, which is really critical. And part of what we're learning during that time is very much like what we had to do here in remodeling the house. We constructed this together. So before we took any tools to the walls, our contractor wanted to know how we lived in our house. Where do you put your dishes? How do you cook? It's really about learning how somebody lives in their own, in this case, a house, but for the therapy, how they live in their own skin. We also get a sense of what kind of complexities might await us, because as we know, some houses are really simple, and others you tear down the walls and, oh my gosh, there's wiring there from 1900, and who knows what it does. So we need to start to understand what might be tucked away in the basement, because that stuff is likely to come up in the psychedelic therapy session. And we want to communicate to the patient that no matter what comes up, we are there for them. And this process of our presence engenders trust. As people trust us, they can learn from us, we can learn from them. This is what Martin Buber referred to as the difference between an I-It relationship, which is one person looking at another as if they are an object, which is objectifying and dehumanizing, and moving that to what we would now call an I-Thou relationship. And it is in this intersubjective space that we really get to understand the world through somebody else's eyes, and they get to understand our world through our eyes. It is different than losing our boundaries. And this is really important to emphasize, because this space can be a little bit seductive. It can be a little bit intoxicating for both patients and for therapists. And so this is where our impeccable behavior is critical, because in order for people to feel safe with that intersubjective space, they need to know that our boundaries are appropriate and solid. So this is that supporting that inner world of the patient through the helping, trusting, caring relationship. How did that feel like? What did that intersubjectivity, how was that experienced? You know, they talked about the sensitivity that you have in that state, that everything, the way they looked at them, their choice of words, all of that really mattered in those moments. And noticing where people's attempts at healing themselves might be emerging. So this was, the subject talked about how the subject had breast cancer. And the therapist pointed out that when she would talk about the breast cancer, she would touch her chest where the cancer had been. And he pointed that out, and he asked about it in a very thoughtful way, which allowed the patient to reflect, the subject to reflect, that maybe what they were really trying to do was to rub out the cancer, to heal themselves. Now, psychedelic therapies can get a little intense sometimes, quite honestly. Anybody who's spent 12 hours in an ICU with a patient with delirium knows that non-ordinary states of consciousness can be kind of intense. That's not to say that everyone in a psychedelic state would be in a state of delirium, but definitely people can have very intense emotional experiences, and that's fine. We don't discourage that. And part of the way that we make space for that is to really hold this empathic, abiding presence with a sense of loving kindness, with something called equanimity. So whatever emerges, we can sit with it. In Buddhism, this idea of a bodhisattva, somebody who has foregone their own enlightenment in service of other people, this sort of calm, quiet presence, that we can be present to whatever emerges during that time without feeling like we have to rush in and intervene. And that's the tricky part, because so often in therapy, we feel our own anxiety bubbling up, and we feel like we need to do something. And so what this is an invitation to do is, can we do as the old bumper sticker said, don't just do something, sit there. Can we wait an extra beat before we speak? Can we take an extra breath and see what emerges? Because often the right action, as the the Tao Te Ching talks about will arise by itself if we allow it to. What should we be doing during this time? In Taoism, there's this idea of Wu Wei, which is doing, not doing. This is my dog here. We got him during COVID, and he's very good at doing, not doing. When he's doing, he's really doing. He's an Australian cattle dog. He's got a lot of energy. But he has these moments where he's just quite content, doing, not doing. And so this idea of being able to respond without having to force a response, and that we don't always have to do something. And the music that we have in these sessions that we should really think about choosing thoughtfully, and hopefully in the future, when we get out of the need to standardize this for everyone for research purposes, we can really maybe even make co-creation of the music list part of the preparatory therapy, so that it reflects the what's important and the background of the patient. But that music creates this kind of current that when things get challenging, you kind of ride that current. But really, the message I want to leave here is that often less is more in these settings. That often the right answer will emerge naturally if we don't force it. And Florence Nightingale had ideas about this too. I mean, she was really a visionary. You got to hand it to Florence Nightingale, because the sensibilities that she taught her nurses are so applicable to what we're doing now 160 years later. Of course, they're kind of wound up in these 19th century language, but she talked about how we often talk at patients to make ourselves feel better. And she called it chattering hopes. She said, we basically think we're making the patient feel better, but really what we're trying to do is make ourselves feel better. And what we end up doing is making the patient feel worse. And so I was taught by one of my teachers, my guiding teachers, this acronym of WAIT, which is, why am I talking? And as you can tell, I have no problem talking. So this is often an important reflection for me as I'm about to say something, to say, is what I'm about to say going to add anything to the beautiful silence that is currently present in the room? The answer is no. Then I try not to say it. And a lot of times we say things because we're trying to be helpful, but a lot of times we're sometimes colluding in the avoidance that a patient might be experiencing. So by distracting themselves from their emotions by talking, we're actually kind of colluding in that. And I'm not saying we need to be silent stoics the whole time, but I'm thinking about a patient that we had in one of our studies who a lot of times would discharge his anxiety by talking all the time. And at one point I encouraged him to really just go inward and see what emerged, as if he was kind of lying in bed on a Sunday morning and had just woken up from a pleasant dream to see what would emerge. He spent hours in that state, that quiet state. So it definitely can be done. We may need to invite our patients into it. And a lot of times when they are having a difficult experience, the natural tendency might be like this dog biting our hand. So my COVID dog loved to bite us when we first got him. He was a puppy. And I learned very quickly that if you try and pull your hand out of a dog's mouth that's biting you, you will succeed in tearing up your hand, because their little teeth are hooked in there to get you if you try and pull out. The trick to getting out of a difficult experience, in this case the dog biting you, is to actually go into it, to push your hand into the mouth of the dog that is biting you. And what happens is the mouth releases. And this is often the case with these kind of difficult moments in psychedelic therapy, is that we need to encourage people to stay with it, or maybe even to go deeper into it rather than rushing away from it. Now, what might happen if we make this kind of space occur? So there is, one of the things I love about a psychedelic dosing session is that we've got all day. We get there at 8 in the morning, 7:30 in the morning. Subject gets there at 8, 8:30. We dose by 9, 9:30, and we're there till 5 or 6. And peak drug effects, if the person was randomized to drug and not placebo, probably going to happen about an hour and a half into it, 2 hours in, and then you've got this nice long coast till mid-afternoon. And the beautiful thing about it is, that's so different than most of my days. Most of my days, my calendar tells me where I got to be and what I got to do. I'm always doing something. I'm always thinking what I need to be doing. And this is such a beautiful experience as a therapist to have nowhere to go and nothing to do. And it's the same for our subjects. And even we always tell them in preparation, because it is a placebo-controlled trial, there's a 50-50 chance that they may not get the drug. They may get the active placebo. And when that happens, we encourage them to still make use of the time to enjoy the music, to enjoy to make use of the two therapists who will be there all day. So the same two therapists that have been with them through the preparation. But often when people do that, one of the things that can emerge is grief. I love this excerpt from a poem by Pablo Neruda, that if we were not so single-minded about keeping our lives moving, and for once could do nothing, perhaps a huge silence might interrupt this sadness of never understanding ourselves and of threatening ourselves with death. And what often does emerge in psychedelic sessions, at least at parts, is grief. And this grief can be released when the ego goes offline. So we talk a lot about egolytic drugs. So, our ego is that part of ourselves that sort of watches our internal and external process, sort of narrates what's happening for us. And, it's probably in part what keeps us civilized, and other times makes us suffer from some of the ailments that we do. But one of the things that it often holds back are things that we don't want to think about. So when that goes down, sometimes there can be this whole lake of unmetabolized grief that lies behind that dam. And that grief can be personal losses, but I'm also seeing that it can be ancestral too. So these are experiences that people had in their family, but maybe even before they were born, or maybe happened to their parents, that they're experiencing the grief of other generations. And I think that's a very deep experience that in our individualistic culture, we often don't make a lot of room for, but have definitely been present in our culture in recent years, as we've seen through Me Too and Black Lives Matter, that there is a lot of pent up ancestral grief that can emerge in various forms, but certainly in psychedelic sessions. Many of us did not get a lot of guidance in how to grieve in our professional training and probably in our lives, which is one of the reasons why I've found, this is a teacher of mine named Francis Weller, who's a psychotherapist here in Northern California, and he's written this beautiful compact little book called The Wild Edge of Sorrow, which I cannot recommend highly enough. But he talks about that we can enter into grief through one of 5 gates, and there may be more than one that applies. And these gates are, one is the obvious one, which is that we will lose everything that we love eventually, but we also grieve the places that have not known love, the parts of us that have not been appreciated or loved, and that we grieve the sorrows of the world, which have certainly been in no short supply in the last few years. But we also grieve what we expected but did not receive in our lives. And that finally, as I mentioned before, we carry ancestral grief. And I found this to be a really helpful map to navigate some of these less obvious forms of grief. The first one is what most of us are familiar with, but there's a lot to be said about the other areas of grief as well. Now, how did patients and their therapists experience having their grief received with loving kindness and presence? And really, it's about being seen. And this subject talked about the transformation and losses that they had experienced through their cancer diagnosis, and that how things change, but nobody tells you how it's going to change. But that in talking with the therapist, there was this sense of kind of a common humanity for being received as just another traveler on the path. Kay Parley talked about how that really when you are in this role, that you are really their anchor. You are the subject's anchor, and that they absolutely need you in order to find their way back. And she would describe that you will go on a journey today for 8 hours, and I will be here the whole time, and I will make sure that you come right back to where you started. Of course, in these experiences of grief and psychedelic spaces, not only grief, but there can be bliss as well, that the spiritual practices of a therapist are important as well. Now, I want to be clear, this is not saying that clinicians need to be adherents to a certain religion or even have a specific practice. But what they do need to do is find a way that they can be comfortable with suffering. And for many people, this is a spiritual practice because in this work, psychedelic or not, we are witness to an incredible amount of suffering. And so we need to be able to fortify ourselves in order to absorb that and to be a conduit for people to pass that suffering, hopefully out into a larger ocean where they are not holding it and we are not holding it either. And that perhaps we help people find meaning in that suffering, which allows for some alleviation from what people are going through. And of course, you might imagine this was important in the cancer anxiety study that we looked at. And a lot of times it was really it communicated non-verbally. That this subject said, there was just something about Peter. They had a look on his face like he understood. Like maybe he'd experienced it himself, but it was just more than that. There was just this noetic quality of being understood. And that really being able to relate human to human. This subject talked about how the cancer diagnosis had made him realize how much we take for granted and get caught up in our lives and forget the meaning of it. We forget what's important. We get caught up with paying bills and making money, and that really just being is a simple pleasure in life that we often overlook. And that the therapist could appreciate that, that really this is about being co-travelers on a path together of being human. And then, of course, many of you in the audience are nurses, and so we know that we also take care of the physical body of a patient. And so this is really important, right? Because we're not just brains going around with fingers. We have a whole body that is part of our human experience and has often been where our traumas have been received. And so we need to be thoughtful about how we care for that body, but also just simple things such as helping somebody get to the bathroom or taking blood pressure, taking vital signs. Those are opportunities for us, what Gene Watson would call a sacred act of tending to basic human needs. And I think this is something that nurses just do naturally. We just naturally touch our patients appropriately, of course. But this is just something that comes normally to us. And it's a really important part of healing. It's something we always talk about in the preparatory sessions. We talk about the possibility of touch. Would the person be okay with that? How would they like that to be delivered? We talk about how they can gesture out with a hand if they would like to have their hand held. And if they can't find words in that moment, they can just pull it back, and we'll read that cue as that they would like to not have touch. But this is something we talk about very carefully and explicitly before the session. And how did that feel to the patients? Well, they talked about how the sense of being well prepared made them feel safer, and that things like going to the bathroom with the study therapist, because they felt safe with the person, because they knew them, that was not a big deal. We walk to the bathroom with the subject, make sure they go in there. Of course, we're right outside the door if they need us. But, it's entirely possible a patient could have an episode of incontinence during one of these sessions, and, we would just help them clean. We'd help them get cleaned up. We have people bring an extra set of clothes, and as nurses, we're not really bothered by that. That is something that really is very comfortable in our wheelhouse. This is the physical setting, so we need to understand how people experience these drugs as therapists, and there are some training programs historically that would actually have therapists go through their own psychedelic experience, which might seem kind of transgressive, but really I would say that's no different than a psychotherapy program that asks its students to go through their own psychotherapy. It's a way of understanding the landscape through which the patient will be transiting. So we talk about having a safe environment of care. This is before we decorated it again, but this is our space at UCSF. Very comfortable living room type environment. you would really not know that you were in a hospital building by looking at this room. It's only when you leave our room and you go past the TMS machine, which is kind of eerie and sci-fi looking, that you realize that you are in a medical setting. But when you're in this room, you could be in a living room anywhere. And we need to think about what sort of techniques might be helpful in complementing the therapy. So, so there will be opportunities for things like aromatherapy or movement. Perhaps yoga might be a useful complement to these treatments to incorporate more of the somatic component. These are all things that can be explored as time goes on once the basic research is done. And of course, nurses are very familiar with the idea of creating a healing environment. This idea goes back to the Greeks because Hygeia, who was the daughter of the healing goddess Asclepius, was the goddess of the healing environment. And of course, Florence Nightingale talked about this in her environmental theory of nursing. She said we need to use the environment as a way of helping people. And the first thing she did when she got to Crimea was to open up the windows, get some fresh air in there, get some sunlight in there, and scrub the place down. So she knew, and by doing that, she drastically reduced infections, which were killing more soldiers than bullets. So she knew that the environment played a role, and so did Timothy Leary. So Timothy Leary talked about the setting is not only the physical, but it's also the things that are going on in the world, the chemistry between the two therapists in the room. All of that is going to be part of the setting, which will amplify or influence the psychedelic experience. And, patients come to love this space. Subjects we have in the room, they really like the space because I think they have such warm associations as this subject did here. And then finally, when this is all over, we have to come back to something we call integration. So integration, as I mentioned before, is really where we make sense of these experiences. And I think about this as a kind of homecoming to our community of where we are from, what matters to us, who we are as a person, really our sense of self. I want to close out with the last part of a wonderful poem, which you should treat yourself and listen to David White reading it himself. It's you can find it online if you search for the audio. But he says at the end of this poem, which is called "Everything is Waiting for You," he says, "Put down the weight of your aloneness and ease into the conversation. The kettle is singing even as it pours you a drink. The cooking pots have left their arrogant aloofness and seen the good in you at last. All the birds and creatures of the world are unutterably themselves. Everything, everything, everything is waiting for you." Oftentimes when we get to integration, people feel a real sense of awareness of where they are in their lives. And Irving Yalom, the great existential therapist, sometimes would do this exercise with patients where he would take a piece of paper and on the left, you'd make an X and say, "This is your birth." You draw a line across, and on the right side, you'd make an X and say, "This is when you die." And he said, "Where are you on this line?" And David White, that same poet, talks about how we live in this liminal frontier between that which is disappearing and that which is emerging. And oftentimes these psychedelic experiences can really amplify the poignancy of that reality. And that what they often result in is people really taking stock in what matters to them, how they're living their lives, and who they're doing that with. And so this integration piece is really critical. It's what differentiates a meaningful psychedelic experience from a novelty. Then finally, once the construction is done, we get to live in our home again. We get to live in this newly refurbished sense of ourselves. This is our home after we finished remodeling. This was our housewarming party. And, this home is sacred. This is where you meet with your family. This is where you entertain your friends. And the beautiful thing is now that the house has been remodeled, it can be reopened to guests. We want to invite people in, and we see the world differently. It's like, my windows look out. I can see far out on the Pacific Ocean, off in the distance, but on a clear day, I can see the Farallon Islands, which are 20 miles offshore San Francisco. And, a lot of times these windows, they get dirty, and I don't see as much anymore. But if I go out there and I clean the windows, wow, it's the same world outside, but I'm seeing it very differently. And I think, that's sort of like what William Blake talked about. If the window, he called it the doors of perception, but if the windows of perception could be clean, everything would appear as it is, infinite. So here's the organization that I was very fortunate to help co-found with my CIS colleagues, Angela Ward, Wendy Marusich, and Liz Willis, Open Nurses. I encourage you to, if this has been interesting to you, to join us there. You can sign up for our mailings on our webpage there. And that's my email address if you'd like to contact me. But with that, I'd like to go ahead and stop sharing and take any questions that you might have.
Wow, that was such an interesting presentation. I think it's really beautiful the way you framed how nurses serve such a unique role in this type of therapy. And I also really like the way you compared your house to the whole therapy process, and it's such an amazing metaphor. And I personally have a lot of questions, and I'm excited to see what the audience also wants to know as well. So just to start, I guess where do you see this therapy going towards, in the next 5 years, in the next 10 years, and moving forward as well? How do you think it's going to be developing in the near future?
Yeah, and we're in a fascinating point in time right now because so the research landscape, as will be talked about in some of the later sessions, so MDMA is in what's called phase 3, late phase 3. So if everything continues to go well, it could be FDA approved by 2023. So very soon. Psilocybin is a little further behind, probably a couple of maybe 2 or 3 years behind that date. There's a lot of unknowns in research. Obviously, nobody expected a respiratory pandemic that would shut down a lot of research for almost 2 years. So 2021 was being batted around for a while for MDMA, and clearly that got interrupted. But it's soon. It's closer than we think. And I think a lot of times people think about that as the end of the story, and I would say it's just the beginning. Really, because what that will establish is that there is a safe way to use these medications and that they can be used in a particular way for particular treatments. Once you have that approval, then you can start branching out and thinking about other ways that they can be used, doing other studies, and it'll be a lot easier because they won't be Schedule 1 substances at that point. They'll be Schedule 2 or Schedule 3. I mean, depends how the DEA decides to reclassify them. But that will allow for a lot of creativity and what are called investigator-initiated studies. Those studies where a researcher says, hey, I wonder if this might be helpful for, say, eating disorders or for methamphetamine use disorder. So there's lots of opportunities to look at this. And then I think we can start also looking at different ways to deliver this care. We're really building the plane as we're flying it right now. And I don't think anybody is exactly sure what this therapy is going to look like in 10 years from now. It's all very speculative, but it does appear that it is going to be available. Now, one of the challenges is going to be having enough people who are trained in doing this in order to deliver it. And I think this is where nurses are really important because we are a ready-made workforce. There are 3.5 million of us, I think, in the United States. And if my hypothesis is true that a lot of what nurses already know how to do can be adapted to psychedelic therapy, then it would probably take only a modest amount of additional training for nurses to be able to deliver this care safely and thoughtfully. And so I think nurses are going to be a critical part of the provider bottleneck, which we are going to face if this is available for prime time. Because my other big fear is that we're going to get the stuff FDA approved, but nobody's going to be able to access it because there's not going to be enough people who know how to deliver it, or that the regulations are going to be so odious that it'll be like buprenorphine, where many people have an X waiver, for example, to prescribe buprenorphine for opiate use disorder, but they don't use it because the restrictions are so complicated. So we have to be really careful that we don't create a new set of problems as we solve the current problems.
Absolutely, absolutely. I remember you talking also about, having the psychedelics delivered, the therapy part delivered over to the phone, and that's going to be a whole different kind of can of worms, I guess we would be dealing with in terms of, how well it's regulated and if it's actually effective and things like that as well. So we actually have some questions regarding, nurses that do want to, use psychedelics in their assisted therapy. So what is the criteria to becoming a psychedelic therapist in the United States? What does it look like in terms of, like certifications or credentialing?
Yeah, it's a great question. Well, that's part of the plane that we're building as we're flying it right now, because right now the term psychedelic therapist is really it hasn't really been defined. So, so one of the questions that's going to need to be answered as this goes through FDA approval is what psychotherapy will be required to be delivered with the drug. And this is where it gets kind of difficult because the FDA is used to regulating drugs. So their job is to make sure that drugs are safe and that they're more effective than placebo. That's their two mandates. They don't know much about therapy. And so the idea of having a drug which goes along with therapy is not something they've had to deal with before. And so they, for example, aren't always clear about who does therapy. So one of their early ideas was that psychiatrists did therapy. Well, most of us know that a lot of psychiatrists primarily manage medications. I mean, certainly some do therapy and some do medication management in a therapeutic way, but the bulk of psychotherapy is done by psychologists, clinical social workers, marriage family therapists, LPCs, and advanced practice nurses. And so it really depends on how that regulation comes to bear. There are some organizations which are starting to talk about future certification for psychedelic therapists. I'm a strong advocate for nurses being included in the list of professionals that could be involved in this, and I would encourage, as this develops, for other nurses to lend their voice of support to that. Because what we don't want to run into a situation where we're playing catch up as a profession as nurses and saying, hey, don't forget about us, because I think for example, a lot of people don't know that psychiatric nurse practitioners are trained in psychotherapy as part of our competencies. We are tested on that, and so that's definitely within our wheelhouse. And so I think it's important that as a profession, as nurses, that we advocate for ourselves. And I think it's really important that we have a voice in the development of these protocols, whatever they look like, that we are definitely included in that, because as I hope to have pointed out today, our profession brings a lot to that conversation.
Absolutely, absolutely. We have some audience members here that are concerned a little bit about safety. They're asking, how frequently do you encounter anger, rage during a session? How might this be prevented and or treated during the session?
Yeah. So, there's this kind of archetype around psychedelics of the bad trip, right? And everyone's heard that term. In the harm reduction work that I've done with an organization called the Zendo Project out of MAPS, we don't use the word bad trip. We say difficult does not equal bad. And so difficult experiences will emerge. People will have strong emotions. Dan Groff talked about that psychedelics are non-specific amplifiers. So whatever you tend to have in your mindset going into the session may very well get louder, may get bigger. And we prepare people for that. So we don't say, oh, you can't get angry in here. You can't get upset in here. We do make agreements. We say, let's make an agreement that you won't harm yourself. Let's make an agreement that you won't leave this room until 7 hours is up. Let's make an agreement that you're not going to break anything in here. And all of our subjects say, of course, I'm not going to do any of that. And it has never really been a problem. We have rescue medications if we needed them. If somebody became acutely hypertensive, we've not had to give that. We have benzodiazepines and antipsychotics if we needed them. We've never needed them. So we have those at our available to us. But really, what does tend to happen with these sessions is that emotions are intense, can be intense. They may not always be visibly intense. They can be internally very intense. So people can be having very intense internal emotional experiences that are not necessarily visible to the outside observer. But the other thing that happens too is that it's kind of like they say about the weather in England. If you don't like the weather, wait 10 minutes because it'll be different. And it's kind of like the same thing with strong emotions in psychedelic sessions, because I have seen people go from like giggling to crying, to really crying in about 45 seconds. So there is a
Wow.
kind of emotional lability that happens in these sessions, but that's not necessarily a bad thing. So we want to make room for all of it.
Okay.
And that's part of our own work as therapists, to make ourselves spacious enough that we don't get so scared that we shut that down, right? So this isn't about being reckless. This is about being a big enough container that somebody can be angry in that room, somebody can be really sad in that room, and that we can hold that space and not communicate to them that those feelings aren't welcome there, because we want to make sure that whatever comes up is welcomed into that space.
Excellent, excellent. That's really neat, and actually leads into the next question. Someone was asking about the specific environment in which the therapy is conducted in. If there's any music being used, if there's any, sensory stimulations being used, like essential oils or anything like that.
Yeah.
What's key to the environment?
Yeah, so the environment is typically kind of like that space that I showed you in one of the slides. So, we say a living room-like environment. So usually there's a couch that we will turn into kind of a day bed so that people can lie back, and we always offer eye shades. We have some really nice, comfortable eye shades, and that allows you. Sometimes people see that picture and they say, "Why is the person blindfolded?" It's not blindfolded. It's like the eye shades you would wear on an overnight flight. And what they allow you to do is really just to relax. You don't even have to keep your eyes closed if you don't want to, but it allows for that inward inward direction of attention. Music is also central to this too. So we'll typically have good quality headphones, and sometimes we'll have the music playing in the room in the background. And it's music that is intentionally selected. This is sort of one of my hobbies. I like to make playlists on Spotify, which I think has sort of fallen into some challenging moments this week. But really finding music that takes people from a very sort of gentle experience to maybe a more intensive experience, and then brings back down to sort of a gentle experience again. And a lot of it is music that does not have words, or at least words that are not going to be understandable to the subject. A lot of it is what you might call ambient music. So it's music that really kind of holds that space beautifully, if it's sort of like if you've ever watched a movie with the sound off, a movie that would make you cry, and you'll notice, like, I'm not feeling the same emotions, right? It's amazing the effects that music has on us. And interestingly, I just learned today that Florence Nightingale talked about music as a healing modality. And
Wow.
she talked about how certain music was really helpful for patients. So, Florence Nightingale would have been an amazing psychedelic therapist had she lived long enough.
Yeah.
I think she was dialed in to these sensibilities that really nursing brings to this work. So that's what it looks like. We have, ideally you'd have a study room that has a bathroom attached, en suite. We have to go down the hall to ours, which is not ideal, but that's what happens when you work in a building that was built in 1950. So there's those kind of things are nice to have. I personally, in the future, would love to do this work outside. I would love to have a little cabin in the woods somewhere where people could be outside and have fresh air, sunlight, trees, a really beautiful, peaceful setting that allows people to really feel this kind of connection with a larger sense than just themselves. Because that's something I didn't really talk about in here, but people talk about these unity experiences in psychedelic states with the natural world, with other people. And a lot of that, I think, comes from that temporary dropping of that ego. Because one of the things that ego does, and it's a useful function in some ways, is to tell us, like, it's like our skin. Our skin is important. I mean, we all know what happens to people in burn units, right? Like, if you don't have an intact skin, you're in trouble, because now the inside of your world is communicating with the outside world, and there's a lot of perils out there in the outside world. In that ego, in that decreased ego state, we can feel a sense of connection with the larger world, but we can also sometimes realize, like, how much we've been participating in our own separation. And that perhaps that sense of separation is really at the core of many of our maladies, regardless of what section of the DSM they're in. That these are really diseases of disconnection. and that maybe we have that transient moment where we feel a connection to something larger than ourselves, larger than our own story, larger than our own suffering, and that maybe getting a glimpse of that allows us to believe that it is actually truly possible. These speculations, but there you have them.
Well, that's really, really neat, and that almost kind of goes into a little bit like psychoanalytical with all the ego and the development of that in the childhood and how it kind of translates into adulthood. That's really, really interesting. And then I think we just have enough time for one last question. The question is, at what point in the psychedelic experience do people begin to experience the healing nature of it? So I guess at what point is the ego starting to dissolve, maybe?
I mean, I would say that people probably start healing the minute they decide to do this treatment. I think a lot of healing happens before we ever enter the therapist's room.
Wow.
Because it's, I used to have a teacher that said action follows intention, and so it's when you begin to intend to make a change, then it's kind of like what the German poet Rilke said about you have to live into the questions. And so I think that and this is why we have such challenges with people starting to get better at the beginning of a session before they even get treatment, which is something we have to guard against in research, because then you don't know if the treatment actually was what made the difference, or if you don't know if it was the drug that made the difference, or was it just the larger treatment protocol. But when we get into clinical work, and this is outside of research, that's not going to matter so much, because people aren't going to care if, why they felt better. They're just going to be happy they felt better. And so I think a lot of the benefit starts to happen as we intend to do the work. But then I think the other big place where healing really begins to happen is in the integration part. Because without integration, it's just kind of like it can be just like a strange experience, that you're not sure what to make sense out of it. But it's really in that integration that we see how the things that we experience in the dosing session relate to our world and perhaps the changes that we're wanting to make. And that is the opportunity that we're trying to leverage in that window of time after treatment. And one of the other big questions that we don't have an answer to yet is, we have a little bit of data, is how long does this last? And there has been some data that indicates that this may last for months, even years. There's so much enthusiasm that people sort of started talking about cures, which, I'm all for it. If we can do it, let's do it. I would love to move out of the palliative model and into a curative model. But even if we only have to do this like once a year or twice a year or something like that, still, I think there's a lot of benefit to that. And you're also avoiding the downsides to, say, having to take a medication every day that gives you side effects. So this kind of procedural episodic treatment instead of this sort of chronic treatment that we do now. So these are all potential changes in the delivery of healthcare as we know it.
That's, I guess, really, really exciting to see what the long-term results are for sure going down the road, and see exactly how long that its effects actually last for. And hopefully it is curative. That'd be really, really incredible and amazing. And I can only imagine how expansive it can get if it does kind of get to that point with the research. So it's now 7:56. So this wraps up our Q&A session. Thanks so much for joining us tonight. And a big thank you to you, Andrew, for sharing your knowledge and your passion with us tonight. We hope everyone found that it was interesting and informative. And at the end of this, you'll be receiving an email within the next few days, including a link to the recording of tonight's session, some resources that our speaker recommends, information about nursing continuing education credits, and a feedback survey. We encourage you to respond to the survey and share your feedback as we strive to improve the series. And we hope to create future psychedelic learning opportunities based on the interests and feedback of our audience. So the next session in the series will be on Tuesday, February 15th, once again at the same time from 6:30 p.m. until 8 p.m. Please note that the next session is the only one that is on a Tuesday. All other sessions are on Wednesdays. And just a reminder that you will need to register for each session individually going forward as well. If you aren't able to watch it live by registering, you will receive a follow-up email with a link to the recording. So thank you all for joining us tonight. Hope to see you at the next session.
Thanks,
Thank you so
Beck.
much, Andrew.